Okay, let's dive into this. Here is our chronological patient management roadmap. We'll start with epidemiology and terminology, then pathophysiology, presentation and examination, investigations, the management framework, and finally, prognosis.
All right, part 1, epidemiology and terminology. Let's figure out exactly who is typically walking through your clinic door with this.
While basically every patient is going to come in calling this tennis elbow, in a clinic, we know it as lateral elbow tendinopathy or lateral epicondylalgia, and it is, without a doubt, the most common overuse injury of the elbow. You're typically looking at a peak demographic of folks between 35 and 54 years old, and it almost always strikes the dominant arm. Now sure, tennis players get it, but you are just as likely to see this in a tradesperson, an office worker, or really anyone with a job demanding highly repetitive forearm and wrist tasks. Recognizing this specific demographic profile is kind of your baseline for building that clinical picture.
Moving right along to Section 2, pathophysiology. This is the physiological foundation that dictates literally every decision we make from here on out.
Now, what's really interesting about this slide is this crucial three-circle model. Think of it as a triad. First up, we've got tendon pathology. The absolutely critical thing to remember here, these are non-inflammatory degenerative changes. We are talking collagen disorganization, cell proliferation, neovessel ingrowth. It is not acute inflammation. The second circle is pain system changes. These patients are actually undergoing peripheral and central nervous system sensitization. That means increased local neurotransmitters and widespread mechanical hyperalgesia. Basically, their alarm system is turned all the way up. Finally, circle 3, motor system impairments. You'll see diminished strength in the wrist and hand, but importantly, and this is a great clinical nugget, it usually spares the MCP or metacarpal phalangeal extension. You'll also spot global upper limb weakness and an altered sensory motor control that causes a really flexed wrist posture when they try to grip something, along with a reduced reaction time.
Okay, Section 3, presentation and examination. Let's see how that three-circle model actually shows up in the real world.
When you sit down for the subjective history, the mechanism of injury is almost always going to be a story of repetitive tendon overload. But here is a massive red flag for you. If the onset is highly acute, like a sudden snap, you've got to immediately suspect a tendon tear. Usually, though, they'll describe pain localized over the lateral elbow that kind of shoots down into the forearm. Functionally, they're going to complain of pain and weakness doing basic daily stuff, gripping, lifting a kettle, or fiddling with small objects. Oh, and definitely keep an ear out for coexisting neck or shoulder pain. It's an incredibly common comorbidity.
So you get them on the plinth for the physical exam. Your palpation is going to reveal pinpoint pain right over the lateral epicondyle, or the common extensor origin. When we do our provocation tests, you're looking for pain with passive wrist flexion and, crucially, pain with resisted wrist extension. And you absolutely want to test resisted second and third finger extension. That isolates the common extensor origin anatomy perfectly. Hit that and you'll hit the nail on the head. Grip testing will also usually reveal a significantly decreased pain-free grip, that flexed or deviated wrist posture we talked about, and they'll struggle to disassociate wrist and finger extension.
So the crucial point is figuring out if manual therapy is actually going to work for them. We do this using the treatment direction test, which is an assessment-reassessment technique for mobilization with movement, or MWM. Step 1, get a baseline. Usually, you test their pain-free grip strength. Step 2, you apply a manual glide. This could be a lateral elbow glide, a PA radial head glide, or maybe even a C5, C6 cervical lateral glide. Step 3, while holding that glide, you immediately reassess that grip strength. You are looking for a massive immediate jump, sometimes like a 50% improvement. If you get that, you know manual therapy is the right path for this specific patient.
Moving to Section 4, investigations. When do we actually need imaging?
Well, ultrasound has a 90% sensitivity for this condition. Let's put that into perspective. It means the absence of ultrasound findings effectively rules the condition out entirely. If the scan comes back clear, no way is it lateral elbow tendinopathy. That should instantly prompt you to investigate differentials. You got to start thinking about radial tunnel syndrome, posterior interosseous nerve entrapment, radiohumeral joint issues, or referred pain from the C5, C6 level. Ultrasound is also fantastic for spotting large tendon or lateral collateral ligament tears, which obviously changes your whole game plan.
All right, Section 5, Management Framework. Let's design a rehab program that's actually backed by science.
Dr. Vuvon has some strict criteria here for designing a management plan. You can't just hand them a generic exercise sheet. You need a comprehensive assessment, clearly defined physio aims, and a deep understanding of what the evidence says actually works. Every single intervention you choose must be rationalized. Why this exercise? Why this load? And you absolutely must have measurable outcomes, like that pain-free grip strength, to prove what you're doing is actually working.
And this brilliantly illustrates the difference between short-term wins and long-term consequences in evidence-based practice. On one hand, landmark trials by Vinzenzino and Pongmalali show us that mobilization with movement provides immediate, superior improvements in pain-free grip and pressure pain thresholds compared to placebo. It's great. But on the other hand, we have the famous Bissett 2006 BMJ trial and the Coombs 2013 JAMA study. These totally shifted the paradigm. They proved that corticosteroid injections, even if you combine them with exercise, do not improve long-term outcomes. Actually, doing physical therapy or even just a conservative wait-and-see approach yields way better long-term results and far lower recurrence rates than jabbing it with cortisone.
Since we are dealing with a degenerative tendon, resistance exercise is the holy grail here. But dosage is everything. You have to progressively overload it. You're going to start them in an endurance phase. Light load, high reps, we're talking more than 15. Then, over a 4 to 6 week window, you transition into an endurance strength phase. Here, you drop the reps to 8 to 10 across 3 sets, keeping rest periods short. Finally, depending on what the patient actually needs to get back to doing, you might push into a high-strength phase. Heavy loads, 4 to 6 reps, 3 sets, with long rest periods in between.
Actually, scratch that for a second. What if their tendon is just incredibly flared up and irritable? You can't just hit them with heavy loading right away. For these highly reactive presentations, the evidence says we start with a strict isometric exercise protocol. You have to be super careful with their wrist and elbow position so you don't flare them up further. The go-to dosage here is 4 sets of 30 to 45-second holds. You might even throw on some deloading tape. Then you only progress the intensity as their symptoms calm down.
Finally, Section 6, Prognosis. What do you actually tell the patient about their recovery timeline?
Let's move to and see how this builds an incredibly reassuring picture. Even if you do absolutely nothing, a pure wait-and-see approach, the prognosis is fantastic. At the 1-year mark, somewhere between 83 and 90% of these patients are fully recovered or much, much better. Communicating this to your patient is huge. It completely deflates their anxiety and sets realistic expectations right from day one.
But, not everyone gets to be in that lucky 90%. You absolutely must screen for factors that signal a poor prognosis. If they walk in with sky-high baseline pain and disability, if they have concomitant neck pain, if you find cold hyperalgesia during testing, or if imaging shows a massive tear, or even if they just have a terrible, highly repetitive work environment they can't escape, those are all massive red flags. So I'll leave you with this final provocative thought. If you spot these poor prognostic factors on day 1, how are you going to immediately pivot your evidence-based management plan to make sure this patient doesn't end up as a chronic statistic?